Good afternoon, everybody. Thank you so much for this opportunity. And I would like to thank Dr. Rita Bakshi, my first point of contact, showing faith in us regarding science and upgradation of gynecologists to the next level. So my point was very clear, not that I'm trying to jump guns, but when we come to overactive bladder, for a diaper-free life for women, I usually checked all the data from the last 15 years, but most of the time either I see refractory or idiopathic overactive bladder. I never spoke about NDO for gynecologist ever. I can give you information, but when it comes to the onus, I'm being very clear that overactive bladder, which is idiopathic, is anybody's subject. I think we can share this like hyperhidrosis. If you see excessive sweating, the neurologist and the aesthetic agree that this belongs to both of them. When we say restless leg syndrome for bottom toxin, it belongs to both. Because eventually, if you see, the cause is not known. If etiology is not known, then I think there should be no objection. So I have taken this courage speaking to Dr. Rita Madam, and she agreed, and she was so sweet. When I came in last month from Mumbai, I was not keeping well because my diabetes was not under control. I was on insulin. She called me home, and what a wonderful dinner, and she spoke to me. She made me understand what is the need of the hour of the gynecologist. And I have tried my best. If you feel that anything is substandard, my apologies for that in the presentation. And if you need anything else, I would request Madam to make a WhatsApp group of everybody for bottom toxin and all indications across, because let me tell you, next year we are getting approval for vaginismus also, officially. So I think when it comes to vaginismus, somewhere gynecologists and urogyne also have some role to play. So I think before it comes, if you start with idiopathic overactive bladder, then you're used to bottom toxin, because if you're doing a surgery, and I was just telling her that when you're doing gynae cases, when you're handling obs with DIC, I mean, then this is just a peanut for all of you. Let me be very frank. Only thing is, imparting the right knowledge in the simplest form will create a new avenue for gynecologists upstreaming themselves, upgrading themselves to the next level. So this is my training institute in Mumbai. I have been very fortunate that Dr. Rita Bakshi and I think one more doctor had attended the training there for cosmetic gynecology. But I didn't have the opportunity there to speak for 3 days. Unluckily, I got only half day to speak there, but maybe next time we will also plan trainings in Delhi, and we will see that whatever newer indications like interstitial cystitis, bladder pain syndrome, you know, all the basic pyriformis syndrome, low back pain, lumbago, where MRI is normal, whatever indications you all feel, chronic migraine, anything that is relevant which is idiopathic is a good idea. I mean, you all should upgrade yourself to the next level. We have 800 indications. At least 80 belong to you all. So these are the doctors who trained me in aesthetic, Ting Som Lim and Dr. Achima Rangshima, Dr. Tatiana Pavek and Niam Kodef. We do a lot of cadavers also. In fact, tomorrow, if you all really take this to the next level, I never said this, maybe in a year or two, we can do a cadaver for injection with the dyes, so that you exactly know where to inject, because cadaver dead body injections are very important. So I am now specialized for cadavers. I have trained doctors in 18 cadavers in Yonsei University, Korea with Dr. Kim, in Singapore General Hospital, and even in India. So basically my main forte is cadaver training for aesthetic, neuro and urologist. So this is, as a trainer, what we do is, we train all therapies like pediatric orthopedic, urologist, gynecologist, aestheticians, and neurologist, and pain management. So we, some training in Harvard as a fellow. This is Niam Kodev, she's a cosmetic surgeon. She is specialized in cadaver training. So, you know, if you have anybody who's training you on the cadaver, you will be the best expert in the world. You know, it's absolutely amazing because you can do 100 mistakes over there. Now, coming back to the real topic. So, Urinary incontinence is your gold standard forte for all the gynecologists. Yes, stress urinary incontinence, urge urinary incontinence, overactive bladder, idiopathic overactive bladder, refractory overactive, and there's a mixed variety where you have urge and stress which is together. So urge is basically when you see urge incontinence, you will always find there's laxity, there is cough reflex. When you cough or you have stress or something, you see that there is leaking in the urine, and there is laxity of the sphincter as well. But when you talk about urge urinary incontinence, there is irregular contraction of the detrusor muscle. So that contraction basically causes the leakage. And third is the overactive bladder, where the contraction of the detrusor muscle is so strong that the bladder capacity goes down by 50 to 60%. So one thing is very sure, first of all, we have to understand whether it is relaxed detrusor or contracted detrusor. What is the situation of the sphincters? What is the nerve supply? You have to actually first diagnose whether it is overactive bladder. Not that anybody who is leaking, we can use bottom toxin. No. If the detrusor is relaxed and if you are giving bottom toxin, it is going to get worse. I mean, it is going to be a nightmare. So you have to understand first when not to inject. The first question is when not to inject. So when you see detrusor overactivity, obviously, the only thing is a urodynamic study. We were just discussing that day that how do you diagnose. I said it is a urodynamic study. I said let us discuss a few markers that would decide that it is overactive, NDO, or whether it is stress or what. So you will have to get the urodynamic study of every patient done on maybe every 2 months or 3 months when you inject. So usually the bottom toxin lasts for around 9 to 12 months, but most of the patients at 7th month, it becomes very difficult. So you will have to inject twice a year probably. So stress urinary incontinence, increased abdominal pressure, laxity, lifting, coughing, causing inner leakage, poor urethral support. So this is the classification so that tomorrow when you do a patient, so there's a machine known as star photo. Now why I put this machine here? So when I say stress urinary incontinence, so whereas there is laxity of the detrusor, so this is what Emsella chair they were talking about. Actually, you didn't see the picture actually. I just gave you a picture about star forward photo now. So it's a high intensity Tesla magnetic stimulation. She was right. I think doctor spoke about 3 Tesla. This is also 3 Tesla machine. This is the non-invasive HITS technology, that is high intensity Tesla magnetic stimulation. So the main focus here is to firm and tone the pelvic floor muscles like Kegels. This is equivalent to 12,000 Kegels, not 15,000. So this is 12,000 Kegels in 25 minutes. So we have this machine here, the first one. So fecal incontinence, even erectile dysfunction, and pelvic floor strengthening and stress urinary incontinence where the detrusor is relaxed. We also have a machine known as Althera which is there at the counter. We are doing a lot of Althera for the pelvic floor. This is micro-focused ultrasound with visualization. So the safe part about this product is that this is ultrasound. Ultrasound will never cause permanent damage. It might cause temporary numbness or temporary pain, but there is nothing that will be permanent. It is one of the safest options that is available for tightening the pelvic floor. But the only thing is, it has 3 cartridges, 1.5 mm depth, 3 mm depth and 4.5. So you should always use 1.5 mm depth first. If the results are not good, then go to 3. Because after 3, it is going to be a little painful. So patients don't like pain. So we have to be careful regarding compliance. They might refuse the treatment. So now coming to the real point, the emerging role of bottom toxin A in overactive bladder. So what is overactive bladder? Urgency with or without urge incontinence, usually with frequency and nocturia. Where frequency is voiding too often, urgency is certain compelling desire to pass urine. Urge incontinence, involuntary urinary leakage. Because in urge incontinence what happens? It basically there's contraction of the irregular contraction of the detrusor. And if you see the OAB, the detrusor is continuously contracted. So there's some difference where there's pulsation like contraction and nocturia, awake at night. So you will see when I'll show you a study and the injection points, you will see actually whether 100 unit works, whether 200 unit works, whether 300 unit works. What is the dilution? How much dilution is required? How much you have to inject at one site? How you have to inject, whether it is deep or whether it's superficial. What happens post-injection? What is the chances that patient may require CIC, clean intermittent catheterization? What are the chances that patient gets UTI? What are the chances that the patient requires antibiotics? What are the chances there is secondary therapy failure? What are the chances that the patient develops antibodies? So all these answers will be, these questions will be answered in these slides. So epidemiology and burden of OAB, National Overactive Bladder Evaluation Program in the US. This is all data which I am showing you. It says that 67% are dry urinary incontinence and 33% are wet incontinence. So conclusion is 33 million OAB sufferers in 16.6% of the population. This is correct. This is 330 million, not 33 million. So this is 330 million people suffering from urinary incontinence. So India is the worst. India is actually, the problem with India is a social problem. People don't talk about it. Now if you ask any lady, na, she will say, "Main to theek hu." You, even if she has OAB, she will not tell you. She is wearing a diaper, she'll wear a diaper for next 10 years. But she will never tell the doctor that this is social, this looks like a stigma. You will have to start talking about it on the social media, on the Instagram, on the Facebook, and tell them to, motivate them to come up and speak up to you. Otherwise, this thing will never pick up. Unless you don't call them, they will not come to you. So what is the prevalence? If you see men and women, yes, they are nearly the same, but in India, this is US data, India, the women are more. If you see, around 70% are women and 30% are male. So more common in comorbidities. If you see ladies who have diabetes or osteoarthritis, they have double-fold chance of developing overactive bladder. Comorbidities is what they have seen in the data. So what is the quality of life issue? Physical limitation of cessation, psychologically depressed, socially reduced social interaction. They don't go for marriages, they don't go for parties, because if she is sitting next to you, one thing you are sure that she is stinking. You will always feel that somebody is stinking next to you, and she feels embarrassed because she knows that you know that she is stinking. And it becomes, then next time they don't go for get-togethers, or they will go for a movie and sit somewhere in the corner. But in a marriage, they will not get close to anybody. They have inhibitions. So this is a very big social problem. And occupational, when they go to work also, they are very embarrassed and they are careful. नहीं, मैं आज एक glass पानी के ऊपर नहीं पीऊंगी. मैं एक सिप, आप लड़की को पानी ऑफर करो, बोलो नहीं नहीं मुझे घर जाना है, 2 घंटे लगेंगे, मैं पानी नहीं पीऊंगी. आपको उधर ही पकड़ लेना है उसको. क्यों भाई, प्रॉब्लम क्या है? And most of the ladies I see, when I see them, when I go to some corporate place, वो घर जाने से पहले पहले washroom जाती है डर के मारे. If you see half of the women, if you start observing these things, when you hear all this, you start observing what happens before they leave for home, or they have to travel for an hour or two. You will see them sitting in the washroom for 10 minutes. But I am not ashamed of saying this, but I want to know whether everything is okay. That's the point. So sexually, if you see, the husband is also not happy because she is not interested in compatibility, because she has other mental issues, she has mood swings. She is already stressed about, in the evening she has to go for a kitty with the friends, and plus she has to wear a diaper, and plus she is going to stink. If she drinks 2 glasses of wine, she is going to stink. This is this is the reality. So you have to first feel it. It's not that you have to learn this. First feel a 20, 25-year, 30-year-old girl who's going to get married. Suppose a 23-year-old girl is going to get married. What does she do? Nobody is going to. Anticholinergics has cardiac side effects after 4 weeks. Palpitations and arrhythmias. It's written on the wall. So what are the options? Antidepressant, is it psychosomatic? I don't know. If it works, it works. If it doesn't work, amitriptyline works. Anything works, diazepam works, doesn't work. What will work? You don't know. So, this is a challenge. When you speak these things, we speak from the heart. It's not that, okay, anything works, but please make her happy. Independence. There's no independence. These patients, ladies, are the prisoners of their disease. They are a prisoner of an idiopathic condition. You have to actually give them freedom. So coming back to the void, if you see bladder, hollow organ with pelvis, average storage is 500 ml, capacity up to 1000. So if you see the pointers, detrusor muscle, you all know about it, the urethra, the external sphincter, the internal sphincter, urethral orifice. Why I am showing you all this? Because in the end, when we show you the injection sites, you will remember that the injection site is like, for example, you have to spare the trigone. You have to spare the urethral orifice, you can't inject. So I will tell you which areas not to inject, which is the wall with a rigid cystoscope, which is the wall with a flexible cystoscope. External sphincter, internal sphincter. So the nerve supply, pudendal nerve, somatic, pelvic nerve, parasympathetic, hypogastric nerve. Basically, what is the mechanism of action of bottom toxin? It reduces the release of acetylcholine at the neuromuscular junction. Hence, it avoids the muscle to contract. So muscle does not contract and it remains in a relaxed mode. So that is how when the detrusor is contracted, the acetylcholine is inhibited at the through the nerves at the neuromuscular junction, that is the motor end plate. How? It cleaves SNAP25. SNAP25 is a snare protein that is there in the cytoplasm, so that releases the acetylcholine. If you cleave SNAP25, the snare protein, the acetylcholine amount is reduced by 90%. So the contraction of the muscle does not take place. First, you have to reduce the acetylcholine release at the neuromuscular junction, only then it works. But the problem is, it resprouts. So it comes back after 6 months, 9 months, 12 months. So you will have to see that whenever it comes back, you have to inject again. So this was just for your understanding for the nerve supply. This is a filling phase. If you see for the bladder. So first, in the empty state, detrusor is relaxed, bladder neck is closed, somatic pudendal nerve is active, external sphincter is closed. This is the actual position. So when after that is the filling phase, okay. So when there is a filling phase, after that voiding phase, okay. So at the voiding phase, internal sphincter relaxes, detrusor contracts, external sphincter opens, bladder neck opens. Why this concept we are telling you? Because this is the contraction, normal contraction and relaxation of the detrusor. Now when there is abnormality, it remains contracted. So you have to understand how much to inject, where to inject and why to inject. So what is actually the management of overactive bladder? First of all, why always bottom line? First is behavioral therapy, drugs, surgery, electrical neuromodulation and biologic neural. Why not? Baclofen pump is also one of the options that is available. Why not? So whatever options are available, you should know all of them. For example, behavioral therapy, keep diet and voiding diary, limit diuretics like caffeine, alcohol, soda, you have to tell them. So when you have a diet chart for them, if suppose it is psychosomatic, you have to first check with this sheet that whether this works. If it doesn't work, then you go for orals. If that doesn't work, then you go for the injection. The first line of treatment is not bottom toxin. Bottom toxin is when everything fails. So it's not that overactive bladder is a treatment of bottom toxin. No. That is your last brahmastra that you are going to use for the patient. Don't abuse the drug by using it immediately that the patient, oh, isko A bhi hai, isko laga do. Aisa nahi hai. First of all, limit diuretics, schedule voids, regular timed intervals. Ask them to cycle, it may be psychosomatic. Ask the patient कि तुम हर 2 घंटे 3 घंटे के बाद यूरिन में जाओ. ऐसा नहीं कि आपको आदत पड़ गई है या वो डर पैदा हो गया, you're scared कि मुझे यूरिन ना आ जाए, तो उस वजह से भी साइकोसोमैटिक भी होता है. Bladder training education is very important. Like we spoke about the machines, she can also go for a Pilates. Why machine? Why you have to buy the machine? If the patient is non-affording, tell them to do some pelvic floor exercises. We had a lovely physiotherapist here. What superb insight she gave us for pelvic floor exercise. I think we need more people like them to help our patients in such situations. So when you see this OAB, wherein you can give pelvic floor Kegel exercises, biofeedback, pelvic muscle contraction, and last is devices like catheters, drainage. If there's a poor patient, what can you do? You can give them a catheter or a drainage bag, or you can give them portable urinals. What else can you do? But you have to give them something. So, ideal drug. What is an ideal drug? This is a dream. You don't have such a drug. You don't have this drug. On the infrequent dosing required, no non-compliance, no adverse reaction, no drug. So there was a saying, a drug which does not have a side effect is a placebo. So what is placebo? I shall please you is a placebo. So the problem is if a drug doesn't have side effect, I'm concerned because then it will not give the result. So at normal dosing, it should not have side effect. Higher dosing, obviously, it should have side effects. So this is a very funny part that somebody says that a drug doesn't have side effect. So anticholinergics, we will not go too deep into it, but I will just tell you a graph which shows that over a period of 4 weeks and above, the compliance of the patient goes down because the drug has a lot of side effects. Eventually, they go down on oral and it gets worse for them. These are anticholinergic and antimuscarinic side effects: delirium, vasodilation, cycloplasia, thermoregulation, sweat, secretions. These are the normal side effects apart from the arrhythmias that happen because of long-term usage of antimuscarinics. There are a lot of, the list is huge, whether it's alpha antagonist, whether it's alpha agonist, the list of drugs that you can experiment. I don't say use. People who use too many drugs on the patient is not like their family member. I respect that doctor who treats every patient as their family member, because if you are keeping on experimenting new drugs on them, it's a young patient, अभी उसको फैमिली कंप्लीट करना बाकी है, या उसकी लाइफस्टाइल पूरी बदली हो गई है ड्रग की वजह से, शी इज टोटली सिक ऑफ द ड्रग, सो eventually she will get into depression. So you see 60% of the patients of overactive bladder are into depression, not only in India, worldwide. The whole study says that. So you have to be very careful. What are you going to? Yes, antidepressant is still okay. Estrogen, I don't know, gynecologist, you are the best judge whether you want to give this drug or no, whether it works. Prostaglandin inhibitors, vasopressin analogs, lot of options we have. We have a whole list of drugs that can be given to the patient, but still the results are not there. The reason why I showed you all these drugs is, if somebody tells me I'm giving this, I gave you the global list of drugs that can be used on the patients. Eventually, intrathecal baclofen did a good job. If you ask a lot of urologists, in idiopathic overactive bladder with detrusor contraction, severe contraction, the baclofen, but the pump cost is very high. It is 5 to 6 lakhs, 7 lakhs, 8 lakhs. I think it is a rich man's treatment. But when you talk about bottom toxin, it is for a middle class person and it is very easy for them to afford it. So if the affordability is there, nothing like it, but it is off label. What we are offering the patient, bottom toxin, is on label. So you will have to take a call whether you want to give both or any one. So I am not talking about only one thing here. I am talking about all the treatment modalities available which you can use in your armamentarium. Now, some doctor told me there was a patient with overactive bladder with bladder pain syndrome, and there were a lot of streaks of blood that are going down, female. So we saw interstitial cystitis, a part of bladder pain syndrome with overactive bladder, idiopathic. So what do? At Kokilaben with Dr. Sanjay Pandey, I was there. What we did was we tried bottom toxin, but the bleeding increased. It was tough for us to handle that case. We started to do cautery, it didn't happen. Eventually, next day morning, we went for bladder augmentation. That means from the colon, we did a complete bladder augmentation of that patient. We had to throw that bladder and make a new one from the colon. I mean, it was a tedious job. So then he told me, the urologist told me that this is one-off case. But yes, if the bladder is too bad and overactive bladder is painful, you can delay the augmentation by years. Not that it will not happen. If the patient is 40, a lady is 40, maybe for the next 4 to 5 years, you can extend the augmentation, delay it. So by giving bottom toxin, so sometimes you can tell the patient that you require augmentation, but I can hold it for some time with bottom toxin. We will see after 4 to 5 years whether you require or no. If luck is good, you may not require. But if you require, we will see about it, because it's not a joke. Augmenting the bladder from the colon is a difficult task, and there are a lot of lifelong problems. This is for those people who have severe bladder pain syndrome. Have you seen, anybody has seen a patient of bladder pain syndrome? They can't sit, they cry, they're crying while lying down whole night. You give them a knife, that is still easier for them. So it's a very tough job. We have seen such patients. So coming back to the point, yes, vanilloids are there. Let's come to bottom toxin. So what are the indications? Forget on label. What are the indications where the studies are there for bottom toxin, where gynecology you should know? So detrusor sphincter dyssynergia, treatment of Okay, neurogenic bladder overactivity, neurogenic bladder trigone base injection, OAB, idiopathic bladder overactivity, obstructive uropathy due to prostatic hypertrophy, interstitial cystitis. Now, interstitial cystitis is a very tricky situation. You will have patients of bladder pain and they come to you, but the only way of injecting these patients is you tell them, first I will use the cystoscope or the hysteroscope, what you use. Let me see the quantity of streaks first. See, the bleeding is a big question. If the streaks get the hemoglobin dull, check the streaks. If the streaks are too many, if you feel while injecting it will get worse, don't inject. Let it go for augmentation. Don't, because bladder pain can be reduced provided the bleeding is, you keep it low, or you do a cautery. If you know the cautery of the bladder, you can do that also. But if the streaks of bleeding in interstitial cystitis and bladder pain syndrome is too high, don't try it unless the beneficence is more than the maleficence. That means the benefit of the injection of botulinum toxin is more than the harm that it can create to the patient for bleeding. So when I say neurogenic detrusor overactivity, why? The cause is known. Whether it is spinal cord injury, whether it is multiple sclerosis, you know the cause of neurogenic detrusor overactivity. When it is overactive bladder, usually the cause is not known. So this is a study of 300 units. Now let's talk about 300 units in a patient of NDO with neurogenic detrusor with spinal cord or multiple sclerosis. So what happens is, I'll tell you what happens. If you take a 100-unit vial, has anybody seen a vial of botulinum toxin? Anybody has seen the vial of botulinum toxin? So clinical baseline is 0, 12 and 36 weeks. You have to do the urodynamic studies. And reflex volume, maximum detrusor pressure, post-void bladder capacity. Bladder capacity is very important. Adverse event, most important is adverse event. What will happen? Patient might require CIC, clean intermittent catheterization. Now the problem here is how long will he require, we don't know. Sometimes they don't require, in 50%. Sometimes they require for 5 days, for 7 days, or 10 days, till they can hold the urine for 4 hours, 5 hours. So slowly they can hold the urine for 6 hours, 7 hours, 8 hours, 9. So the problem is, CIC will be required if you cannot hold the urine for 1 hour. And plus the post-void residual urine. When do you decide CIC? Anybody knows? When do you decide CIC, clean intermittent catheterization for the bladder? If the quantity of post-void residual is between 200 to 350, then depending on the symptoms, you will give CIC. Why? It can cause significant bacteriuria and recurrent UTI. So you need to do CIC and fever. But if the post-void residual urine is more than 350, then irrespective of the symptoms, CIC has to be given. This is the global gold standard by the US FDA. Correct? So in NDO, neurogenic detrusor overactivity, the patient has a cause. 167 patients of spinal cord injury, 11 patients of multiple sclerosis and 22 patients of myelomeningocele. So 180 were incontinent, 20 were dry, but had severe anticholinergic side effects because of the drug. 188 were on CIC. So all those were injected, 188 were on CIC in any case. And 12 indwelling catheter and 92 concomitant. So at 12 weeks, 132 out of 180 patients became dry. That means 73% improvement in these patients. Second is at 12 weeks, 118, 99 out of 200 at second follow-up at 36 weeks. So what happened at 36 weeks? What is 36 weeks is 9 months. So when you are injecting 300 units, what happens at 9 months? 72 out of 99 reported complete continence. Okay, that means not bad. You are not going to get 100% success. It will be 4 out of 5 will be happy, 1 will not be happy, that's for sure. There is something known as primary therapy failure, secondary therapy failure. Then you have to try the second time after 3 months. So suppose you do not get a result with botulinum toxin, then after 12 weeks, not within 12 weeks, because there is a chance of antibody formation if you inject within 12 weeks. After 12 weeks, again you can inject and you can try once more, whether there is secondary therapy failure or antibody formation, that is primary responders. That means they have antibody on the first time of injection. Again, urodynamic study is an important part of this. You can always send the patient for urodynamic study before you decide whether detrusor is contracted or relaxed. So improvement in urodynamic outcomes despite an anticholinergic use. And this is the graph. So the improvements you can clearly see. And another study is of 100 patients, that is in refractory overactive bladder, 1, 3 and 9 months. Now the dosing here is 100 units. Now first I showed you 300 units in a patient in the bladder. Now this is a patient of 100 units. Now you see there are 30 sites to be injected. One site is 0.3 ml. Okay, that means in 100 units you have to put 10 ml. The dilution is 100 units will have 10 ml of preservative-free 0.9% normal saline. That is the dosing, clear dosing. Any overactive bladder, the dilution, whether it's 100 units, 200 or 300, the dosing dilution is 10 ml of 0.9% preservative-free normal saline. And at every site, you can inject at 0.5 to 1 ml. That means 5 to 10 units, not more than 10 units at each site. So, summary and overactive affects approximately 15% of the adults. Antimuscarinic first line is pharmacotherapy. Botulinum toxin A may result from inhibition of acetylcholine inhibition, shown promise in treatment of neurogenic and idiopathic OAB. Other serotypes have not so. Botulinum toxin has 7 serotypes, A, B, C, D, E, F, G. A is the most potent. So A, botulinum toxin type A has shown good results, but other serotypes has not been tested. In the US, there is a new botulinum toxin known as botulinum toxin type B, that is myoblock, that is used when there is antibody formation with A. So when you come to the overactive bladder syndrome affects 12%. Currently anticholinergics are the only approved pharmacotherapy. The new is overactive bladder for botulinum toxin for overactive bladder. This is 755 patients, 577 patients, 6 months. Now this is a study of 6 months where you are injecting 200 units. So if you see 100 unit injection site, so coming to the point, so posterior wall, if you see the site, so what you do, if you see the bladder here, the posterior wall and the 2 lateral walls, you have to spare the trigone and the ureteric aperture. So ureteric apertures and trigone has to be spared. Why? You will get urinary retention and you will have CIC, catheterization for the whole year. Because you cannot relax the ureter, you cannot relax the trigone. So you have to spare that area. So when you see the posterior wall, why I am not showing you the anterior wall? Anybody wants to know why I am not telling you about the anterior wall? Anybody? Because in India, if there are 100 cystoscopes, 99 are rigid. Flexible cystoscope is very costly. Not everybody can afford a flexible cystoscope. Impossible. This is not the US. So if you want to go to the anterior wall, you need a flexible cystoscope. So that is step 2. When you earn a lot of money from this, you can buy a flexible cystoscope, then doing the anterior wall give better results. So if you are injecting the anterior wall, the results are more certain. But the problem is the rigid cystoscope cannot go anteriorly. Don't do it. Don't do it because I'll tell you, nowadays people don't give GA, not even short GA. They try spinal. But nowadays when they are inflating the bladder with saline, they are trying to put 3% lidocaine in the saline. So they don't give spinal also. In that case, you can't move the patient because you have already inflated it with the cystoscope. It's not a hysteroscope. It's a very, I'll show you a video now how terrible it was while doing it. So, but the best part is once you're used to it, it's like driving a car and you're driving a plane, it's okay. Once you learn, it's yours. So posterior wall, if I tell you we are doing 100 units, then 50 units you'll do in the posterior wall. And you will do 25 in the 2 lateral walls. Whatever you inject, 50% you inject in the posterior wall, sparing the ureteric aperture and the trigone. Above that, you 1 inch apart, and there are craters. Just you have to also spare the blood vessels that you see. I will show you in the video how we spare the blood vessels. You cannot cause too much bleeding. You cannot go too deep. You have to be superficial and form blebs. When you are injecting, you should see it coming up like a bleb. If it goes deep, there is no result. It has to form a bleb superficially. If you go deep and if there's no bleb, there's no result. You have wasted the patient's money, the toxin and everything is gone. You will just get weak. There will be no result. So what is the primary endpoint? Proportion of patients with positive treatment response in the treatment benefit scale, number of micturition episode, number of urgency, secondaries, volume void per micturition, QOL, quality of life. Now, what are the baseline characteristics? Age usually 65 years and above. What is the reduction? If you do an injection in a patient, what can happen? At least 50%, 50% reduction in 57.5 patients. That means overall in 22% you will see 100% reduction. And in 57% of the patients you will say 50%. That means your 80% patients will get good results and 20% patients might not be happy. You have to try the second time. So I am telling you what can go wrong first. Not that a gloomy picture. That means this data, that is US data, shows 2 out of 10 may not be happy with the results. So you will have to tell them you might require a second session after 12 weeks if you are not satisfied. If you are ready, we will start. So you prepare them for 2 sessions, not 1. So you have to be very, very frank. If you see the results are good, micturition episodes have reduced. And if I show you data, look at this. Urinary incontinence reduced by 47%, micturition reduced, urgency reduced, nocturia reduced. But this is only with 80%, 20% do not have. The results are good, treatment benefit scale is good, questionnaire is good, the results, sleep, everything. If you see the results, these are the side effects. Now, what will happen if after injection patient comes to you? Patient may have UTI, dysuria, bacteria, urinary retention, hematuria. There will be 10 things. You will have to handle this in maybe 2 out of 10. So 3 out of 10. So these are the things that may come to you. You will have to take care of the patient. These are the side effects that come in. So treatment with 100 units, 200 units and 300 units. But dilution in every 100 unit, the dilution is 10 ml of 0.9% normal saline. And at the end of the day, probably Dr. Rita Bakshi might be keeping a master class for hands-on training for this, because this is just the theory. If you want to do it yourself, we can even do it live in Delhi. So this is the botulin toxin. What is the botulin toxin? So if you see, these are the basic inventors, and out of them 2 is whom I met. Alan Scott is my god. I have met him 2-3 times. He's taught me a lot. Recently in June, I met Dr. Gian Carithis and the husband in the ad board in the US. I was in Boston. They are still alive and they are doing extremely well. So it's a 900 kilodalton complex. What is botulin toxin? It's a 900 kilodalton complex. 750 kilodalton is the complexing protein which is made up of hemagglutinin and non-hemagglutinin, and there's a light chain and a heavy chain. So light chain is 50 kilodalton, heavy chain is 100 kilodalton. This is the molecule, okay. It is a lyophilized powder of 100 units that contains 0.5 nanograms of human serum albumin and 0.5 nanograms of sodium chloride. So in this lyophilization, there is a vacuum. When you put saline in that, it sucks the saline in it 4 ml, and then you take 6 ml saline in a 10 ml syringe, plain saline, and add this 4 ml of this botulin toxin in that, so you get a 10 ml syringe. You get a Cook's needle which is 35 inches in length, and the tip is 8 mm. So you have to inject 1 ml at each side from each syringe of 10 ml, so that whether it's 100, you will have 10 ml. If you have 200 units, you will have 20 ml. If you have 300 units, you will have 30 ml. So I told you about the SNAP 25 and the botulin toxin. This is the botulin toxin that is there. Now my question to all of you is, this is the another thing which I was coming to. What are the approved indications in India otherwise? That is glabular frown lines, forehead lines, crow's feet, and hyperhidrosis of the axilla, palmar and plantar. So how do you look at it? This is how it looks. So glabular frown line, there is a procerus and corrugator. There are 2 muscles. This is the injection site. Each site is 4 units. There are 5 sites, which is 20 units. Now the only question is, keeping your urology and gynecology aside, the dilution here is 2.5 ml in 100 units. And in OAB, it was 10 ml in 100 units. So 2.5 ml of 0.9% preservative normal saline in 100 units. And in OAB, it's 10 ml of 0.9% preservative normal saline. So other approved indication is crow's feet, that is outer canthal line. 3 sites, 4 units at each side. Because when a patient comes to you, it is usually a lady. In the end, what happens is they eventually need this also. So this is also an approved indication, and these forehead lines is a M. If you see an M, so there are 5 sites of 4 units, or you can take 10 sites of 2 units, maximum 20 units. How do you do it in axillary hyperhidrosis? You paint iodine in the axilla. First you shape the axilla, paint iodine in the axilla. From a general store, just sprinkle starch powder in that area. In 5 minutes, wherever there is excessive sweating, you will get stains. And wherever there are stains, you just have to inject intradermal 2 units. That's it. So 25 units in each axilla is maximum, 50 units. Same goes for palmar, same goes for plantar. For glabular frown lines, there are 5 shots of process, 1, 2, 3, 4, 5, I showed you, 4 units each. Same goes on the crow's feet, 4 units each. Forehead lines, you have to make a M of 4 units each, 5 shots. These are all approved indications which I am telling in India, which is actually the game changer for all the doctors in India, and this is what makes them millions. So what are the other applications? Very interesting. Square jaw, dimple chin, neck lines, bunny lines, gummy smile, eyebrow sculpting, hyperhidrosis in the other part of the body, non-dermatological, ophthalmology, strabismus, squint, hemifacial spasm, blepharospasm, then overactive bladder, of course, neurology, chronic migraine, cervical dystonia, neck pain, okay, focal spasticity, anything. So there are so many indications, 800 of them for you all. What is the treatment planning? Identify the muscles to be treated, know the anatomy. Determine amount of toxin to be used, knowledge of drug dilution and diffusion. Never change the dilution which is given by the US FDA. Please don't try to disperse it too much. Patient will get ptosis, patient will get side effects. So, and the depth also you should know. This is just theory. Training, Dr. Rita Bakshi is there. She will tell us when and how we are going to arrange the training. Whether it is overactive bladder or all the other indications that you want to know, you can request according. क्या है ये? क्या है मैडम? Madam, homeopaths are not allowed. NMC guideline says anybody above MBBS, even a dentist has got the approval right now. This is the yesterday's NMC guideline I am telling you. कल आया है, तभी तो मैंने अभी डाला उसको. Madam, anybody who's above MBBS, he can be an orthopedic, he can be a gynec. MBBS is minimum. Botulinum toxin and HA fillers both. NMC has approved with IMA. Narendra Modi has given a go ahead. मेरे को एक बात बताओ, एक सर्जन को अगर लगाना अलाउड नहीं है तो कोई क्वैक लगा सकता है? सलून, यूएस में सलून के अंदर. मैडम, आपको जब IIDVL डराता है ना, मैं बताता हूँ आपको, IIDVL इज नॉट द अथॉरिटी. अथॉरिटी इज NMC, नेशनल मेडिकल काउंसिल. IIDVL तो बोलेगा मत लगाओ. NMC is the IMA substitute. Whatever NMC says, we do that. So these are, next time I will talk to you about fillers that can be used by gynecologist. Why? I want you to learn under eye, dark circle, teardrop, nasolabial fold, marionette line, pre-jaw sulcus, jaw line, facelift. क्या? मैं आज नहीं सिखा रहा हूँ. इसके पैसे अलग लगेंगे. मैं गुफिक से ले लूंगा अगले दिन के. ये अभी इतना ही, इतने पैसे में इतना ही हो गया. अभी तो मैडम, अभी हेयर फिलर मैं आपको सिखाने वाला हूँ. अब रुको, अभी दिस इज A of Z. A to Z में मैंने आज सिर्फ A बताया आपको. सो डाइल्यूशन, दिस इज वेरी इंपॉर्टेंट. दैट इज नथिंग. हाँ, Masseter's is the best for slimming your face. अनुष्का शर्मा का डोनाल्ड डक वो फिलर है. So the dilution is 2.5 ml in 100 units for these indications in approved aesthetic indications I am telling you. So now the new thing that has come is aesthetic gynecology. So it has to be injected every 3 to 4 months.
It's a bleeding from 2.6.
For the face, every 4 months, thrice a year. I answered your question, right? Yeah, what should I do in my clinic practice? Am I correct? I answered most of the जो मेरे से पूछने आए थे 20-25 लोग, मैंने उनका जवाब एंड में खाली स्लाइड्स डाल के दे दिया कि what are you going to do in your clinic? We have answered that. Am I correct?
Excuse me, sir. So what about Dysport? Sir,
Yeah, Dysport is a good product. The only thing is the dispersion of, I'll tell you, the dispersion of any brand of bottom toxin is 1 centimeter square when you inject. Dysport is 2.5 centimeter square. It is very good for the body contouring. We are doing body contouring of trapezius, biceps,
sir,
gastrocsoleus.
to develop antibodies to Botox on chronic use, because if they're using every 3 to 4 monthly, they develop antibodies.
So antibodies are developed if you use within 12 weeks or 3 months. It doesn't form otherwise.
So actually, I read somewhere it's with using Dysport, the antibody formation is lesser.
Where is the data? I will give you the data because all the molecules, I'll tell you, when do antibodies form mostly 99% is when you use within 3 months. Any brand, whether it's Botox or Dysport, if you abuse the drug, see if you are taking, I'll give you an example, you take paracetamol 3 tablets a day for the next 5 years, it will not work after that. Same happens with this also. When we are telling you every 3 months, if you are injecting every month, so you are abusing the drug, right? That is where the problem starts. It's not the company's fault. This is a problem of the doctors who are abusing the brand.
So it was a wonderful lecture,
Yeah.
and I gained a lot. And sir, I want to ask one thing: that why the blab making is necessary for effectiveness of botulinum?
So superficial injections are required for botulinum toxin because it's a neuromuscular junction. If you go deep, you might go deep into the layers which are not required, and that may cause more weakness, and the results may be exaggerated.
Okay. And
Keep-
why it is anteriorly or posteriorly? You said that anteriorly is more effective and the posteriorly less effective. Is that?
No, I didn't say that. I said in a country like developing country like India, you will not find a flexible cystoscope where you can go to the anterior wall.
But hysteroscope is a 30-degree and we can inject.
You cannot use a cystoscope, madam. Cook's needle, you have to use a cystoscope.
Yeah, I understand the system.
Cystoscope, 99% of the cystoscopes are rigid.
that is it.
So you can go on the posterior wall and lateral wall, but you cannot go on the anterior wall till you have a flexible cystoscope.
But with the hysteroscope, we can go on anterior wall.
Yeah, but you want to experiment, you do it. Let me know whether it goes.
Anterior wall we can easily visible.
The
every
problem
day we
is,
do the cystoscopy.
I am not going to agree on something which is ethically not, which is ethical. So, but don't let me know about it. Because if you are doing something which is not there in the data, I'll tell you one thing. See, if you go to US FDA guidelines, they are very clear. You have to inject with a cystoscope, not with a histoscope. If you want to do that, you create data and publish it. Nobody is going to tell you no about it.